Finance and Policy Committee. Today's date is February 16th, 2022. Welcome to our meeting, and today we are going to hear, we're going to review the governor's supplemental budget by Commissioner Harpstead and staff, and then we will finish up with a MNsure report. So welcome to our committee. Commissioner Harpstead, it looks like according to our agenda, you're going to start us off today, and then you'll have some staff with you to cover some sections as we go. So welcome.
Thank you. Good afternoon. Chair Utke and members of the committee, I'm Jody Harpstead, the Commissioner of the Department of Human Services. Grounded in their vision for One Minnesota, Governor Walz and Lieutenant Governor Flanagan's proposed budget to move Minnesota forward is a balance of key investments in four main categories: local jobs and projects, expanding economic opportunity, supporting kids and families, and protecting health and safety. You can see how the DHS portion of the supplemental budget breaks out. The first biennium is a total of $484.6 million. The second, $1.742 billion. And you can see how it breaks out versus the various funds that flow in and out of the Department of Human Services. Next slide. The governor's supplemental budget includes proposals that address the challenges we face today while investing in the future to ensure we emerge from this time of crisis stronger than ever before. The DHS budget is a mix of new investments in priority areas, as well as funding to make sure basic services such as our direct care and treatment programs have the support they need. And you'll hear from us about proposals in each of the categories here on the screen today. I'm going to start with our proposal for the caring professions workforce. The governor recommends revitalizing the state's behavioral health, direct support, and housing workforces by establishing a workforce incentive fund. This fund could be used to offer additional compensation, including but not limited to retention payments, hiring bonuses, and financial assistance for post-secondary education, loans, and scholarships. Employers in these industries would be allowed to apply for grants to deliver these incentives to employees who've been employed for 6 months or longer for an investment of $115 million in the first biennium. Chair Utke, I believe that Chuck Johnson, our Deputy Commissioner, is next to speak.
Welcome, Mr. Johnson. Go ahead with your testimony, and thank you.
Thank you, Mr. Chair. For the record, my name is Chuck Johnson. I serve as Deputy Commissioner for Operations for the Minnesota Department of Human Services. Thanks for the opportunity to present today. The first proposal that we have is our service delivery transformation proposal. This is a proposal to really address the issues that we have with our current IT infrastructure and how it affects services to people and our ability and the county's ability to manage those services. It's a request for $77.5 million that will leverage $107 million in federal funds to implement a go-forward strategy roadmap that was recommended by Gartner Consulting, who've been working with over the last couple of years. The strategy will build user-friendly processes and IT solutions to greatly improve the experience of those supported by human services programs and improve inefficient processes and fix and maintain our legacy IT systems. This supports our vision of a person-centered integrated human services delivery system, which was developed in partnership with counties and tribes over the last 5 years or so. Right now, we have a lot of barriers for customers and for counties in managing our programs. Consumers can't access services, can't access the full range of services. County tribal workers struggle to provide services effectively and efficiently due to old and inflexible IT systems, which in themselves create some risk of failure and are difficult to maintain. This process will move forward in a way that's consistent with the recommendations of the Blue Ribbon IT Council that I served on, as well as Senator Wickland and Senator Curran. It will move us toward a agile product way of delivering services, which is to look for more incremental opportunities to improve services by doing smaller pieces of work and linking them together and building across a common integrated platform. This is to really replicate the success we've had with MN benefits, which is a tool that we launched statewide last fall. Mobile-friendly application allows the user to apply for SNAP, diversion work program, all the cash programs, emergency assist, housing support, and CCAP in about 13 minutes average, which is down from over an hour with our old application. And we'll do this work, as I said, consistent with both our recommendations and the map that the Blue Ribbon Commission developed for how to do modernization in state government. The first application, our initial focus will be on eligibility and enrollment, which is the front door for most human services programs and a process that right now is full of pain points and in need of improvement. Next slide. The next request is for an electronic health record for our direct care and treatment area. This would implement a fully compliant and fully functional electronic health record for direct care and treatment, would improve compliance and make us more efficient, support safe and high quality care, would help us monitor equity outcomes, and enhances the continuum of care. In 2008, the Department of Health mandated all healthcare facilities in Minnesota to have an electronic health record in place by 2015. Direct care and treatment has not met this timeline. We have been using operational funds over the last several years to develop an EMR, but we need additional funds to accelerate and complete that development work. Lack of a functional EMR significantly impacts DCT's efficiency and ability to provide quality care and treatment to patients and clients. Right now, we have about 300,000 filing inches of paper records and over 100,000 patients and clients. To get a complete understanding of a patient or client's record often means boxes or binders of records, and may mean going between paper records and electronic records to get the full picture of the individual's health history. We don't have any routine way to track or any way to track routine health issues, electronic health issues, vaccines, and so forth. We rely on spreadsheets and other tools to do that. This proposal would complete the EHR in 2 phases. Phase 1 would implement an electronic medical record across DCT that will replace the paper files and allow tracking of care over time. The EMR must be in place before a stable electronic health record can be done, which is phase 2, and that's developing the fully integrated electronic health record that would allow us to track the whole person over time, provide better care and coordination across our facilities, and also an ability to share information with other healthcare providers. Next slide. This proposal it enhances DHS's ongoing effort to improve agency and compliance process controls. When we saw payment issues in 2019, Commissioner Harpster took immediate steps to address the issues that we identified. We also took steps to prevent these issues from occurring in the future. To further develop and enhance our agency compliance rules, we fully implemented a compliance structure and reporting across the agency, focusing on closing audit findings and mitigating known risks. We also asked our Office of Continuous Improvement to implement Operation Swiss Watch to directly address Medicaid payment issues and the management of grant contracts, 2 issues that have been identified as clear problems within the agency. This proposal will help us strengthen our compliance and process controls by addressing areas of critical staffing need, and by investing further in our continuous improvement efforts, expand our capacity to examine and improve process controls. We're asking for 19 staff. 7 of these would be continuous improvement. Those are the black belts and green belts who help us examine our processes. We're asking for 10 staff in our contract division. This is both to keep up with contract volume. We are using overtime now to keep up with the volume of contracts, and to build an agency-wide contract compliance monitoring function, including a contract database. In addition, we're asking for 2 auditors for internal audits division to move us more toward a risk-based analysis of program payment and rate setting practices. This slide also contains another issue, which is a request for $228,000 one time to support drug price litigation costs. Minnesota Attorney General Ellison has joined several lawsuits for drug manufacturers that are conspiring illegally to fix prices and allocate markets. We're not a party to these lawsuits, DHS isn't, but we did receive a subpoena to respond to some really extensive discovery requests. The only way we can do that is to hire a vendor to help us manage the discovery. And this $228,000 would allow us to do that. Thank you, Mr. Chairman. I believe I'm handing it off to Inspector General Moti.
Thank you, Mr. Johnson. Welcome, Ms. Moti, and please identify yourself for the record and continue with your testimony when you're ready.
Thank you, Chair Upke. For the record, my name is Kulani Moti, and I serve as the Inspector General here at the Department of Human Services. Chair Upke and the members of the committee, I am here to speak on two proposals specifically for the Office of Inspector General. The first is for our critical resources for licensing. The governor recommends providing funding to address growth in the number of foster care and home and community-based licenses and applications, and address the growth in the work related to our maltreatment investigations. From 2014 to 2021, there has been a 139% increase in the overall licenses that we issue. And since the inception of the Home and Community-Based Services, or HCBS licensed services in January of 2014, the number of service types that may be licensed under a 245D licensure has increased from 19 to 31, which has been a significant increase in the amount of work needed to process applications that we receive. We've also seen an increase in the number of foster care applications being submitted, and the number of maltreatment complaints that we have received has doubled over the last 6 years. So without additional resources, this increase in workload has caused license application processing times to increase significantly, has greatly lengthened the time between our HCBS licensing reviews, and has negatively impacted the timeliness of our maltreatment assessments and investigations. So this request would provide additional staff, specifically 43, and if funded, would give us the ability to reduce the amount of time it takes to process all of the licensing applications in our HCBS and foster care areas, reduce the time between the HCBS licensing reviews to at least once every 3 years, and to ensure that statutory timelines for maltreatment complaints are met. Next slide. This proposal is for one-time funding to credit providers for the cost of emergency background studies conducted since July 2021. This funding request is similar to the request that was included in the budget last year, which gave a credit to providers for the cost of emergency studies that were conducted between April of 2020 and June of 2021. And just as a reminder, during the peacetime emergency, the department waived or modified several state background studies requirements and conducted what we have termed as emergency background studies, and there was a fee associated with this. And so this one-time funding would credit that fee back to the providers as they begin to transition to the new studies. And I believe that concludes my portion of it. And I believe the next presenter is Assistant Commissioner Gertrude Mutamba-Mutasa.
Thank you, Ms. Moti, and welcome to our committee, Ms. Mutamba-Mutasa. I hope I got somewhat close. So again, welcome, and please identify yourself and continue with your testimony.
Thank you, Mr. Chair. And yes, it is Mutamba-Mutasa. You got it correct. My name is Gertrude Mutamba-Mutasa. I currently serve as Assistant Commissioner for Community Supports Administration in the Department of Human Services. I just have one slide. The governor recommends changes to Opiate Epidemic Response Advisory Council composition and the Opiate Epidemic Response Fund distribution of funds. This includes expanding the membership of Orac to include a representative from all 11 federally recognized American Indian tribes. Currently, only 2 have membership with Orac. Additionally, it would require that 40% of the Orac grants are awarded to projects that have culturally specific or culturally responsive components. The proposal would continue existing funding for traditional healing grants in the base, starting in fiscal year 2025, which are currently set to expire. The proposal also includes additional funds for grants administration and for instituting a reporting structure for counties to ensure the settlement dollars are used properly. This will include measuring outcomes through impact evaluations, and that it concludes my portion. I'll hand it over to my colleague, Assistant Commissioner Cynthia.
Thank you very much. Welcome, Ms. McDonald. Please identify yourself and you can continue with your testimony.
Very good. Hopefully my camera works. Wonderful. Well, thank you very much, Mr. Chair and members of the committee. My name is Cynthia Mcdonald, and I serve as the Assistant Commissioner for the Healthcare Administration and also the State Medicaid Director at DHS. And I'm really pleased to have the opportunity to be with you this afternoon to share our portion of the governor's priorities for healthcare in the supplemental budget. And overall, these proposals strengthen and expand our public health care programs in order to ensure that Minnesotans have access to comprehensive health coverage. And I'll highlight our 6 proposals today, starting with the first one that you see on the screen, continuous medical assistance eligibility for children under age 21. Here, we're recommending that we change medical assistance eligibility for children under age 21 to give them 12 months of continuous coverage. This change is expected to result in an average of over 50,888 children a month to retain their medical assistance coverage. And continuous eligibility means that a child determined eligible for medical assistance remains eligible until their annual renewal time, regardless of most of the change in circumstances that are happening around this child's life that would ordinarily cause the child to lose eligibility during the year. I'll just note that 23 states have implemented 12 months eligibility in Medicaid, and an additional 25 states have implemented continuous eligibility for children in the CHIP program. I'll go to the next slide. Our second proposal is around medical assistance for former foster youth. And this proposal amends state law to comply with the Federal Support Act requirements regarding medical assistance for former foster care youth. It's effective January 1st, 2023. A person who was formerly in foster care on their 18th birthday and receiving Medicaid in any state where their foster care ended will qualify for medical assistance as a former foster care youth in Minnesota until age 26. I'll move on to proposal 3, next slide. This is coverage for undocumented children, and the governor is recommending expanding the Minnesota Care program to provide coverage to undocumented children under the age of 19. This is a state-only funded Minnesota Care expansion and estimated to provide healthcare access for around 1,700 children living in Minnesota once it's fully implemented, which would be January 2024. I'll move on to proposal 4, which is enhancing the Minnesota healthcare program's COVID-19 vaccination rates. Here we are recommending funding for community outreach grants to supported trusted messenger programs, those programs and those communicators that are trusted in the communities, and then culturally informed community-based providers as well to encourage vaccination against COVID-19 and other communicable diseases. This would include a variety of outreach methods to encourage vaccination, answer questions, and provide information. And these grants would be made available statewide, and organizations from and who work with communities that have the largest disparities in vaccination rates would be prioritized. I'll move on to proposal 5, which is removing the doula supervision requirement. Here we're recommending removing the requirement that doulas be supervised by a licensed provider to be eligible for payment under the medical assistance program. Removing this requirement will expand access to doula care, which is linked to better maternal and postpartum outcomes. And as a result of this change, doulas would directly enroll as providers and then be able to receive direct payment from the state. And then our 6th proposal is labeled as improving healthcare access and affordability. And in this proposal, we're recommending taking a 3-pronged approach to reducing the number of Minnesotans who are uninsured and improving affordability of healthcare for Minnesotans struggling to pay for the insurance they have. The first prong of this approach is that this proposal reduces barriers to already existing coverage options by improving the experience of people who are on the program and applying, reapplying, or seeking to apply for public health care programs. It includes some operational process changes. The second prong of the proposal expands coverage options by modifying existing medical assistance and Minnesota Care programs and creates a product that Minnesotans can purchase to help address the affordability of their health care. These coverage expansions are twofold. It establishes a Minnesota Care buy-in that permits individuals with incomes over 200% of the federal poverty limit. 200% for a family of 4, to give you an idea on that, is $53,000. So people over that amount to purchase into Minnesota Care. And then DHS would develop a sliding fee scale around that to pay for that premium. Also, under the American Rescue Plan, Minnesota was required to reduce Minnesota Care monthly premiums for calendar years in 21 and 22 to conform with limits on healthcare premiums. This increased the number of individuals who had access to the $0 premium health insurance and reduced the maximum monthly Minnesota Care premium to $28 per adult per month. And this recommendation makes these Minnesota Care premium reductions permanent. And this recommendation also includes funding for additional staff to operate the Minnesota Care buy-in and investments in the state's healthcare systems infrastructure. And then third and last is that third prong. And this proposal invests in system infrastructure and existing enrollment processes to improve the enrollee experience for public programs and streamline the consumer experience across public programs and the individual marketplace. A new system would be more nimble and responsive to changes in federal and state law. And these investments would improve the experience of 1.4 million people who access their health care through our programs, through technologies, and streamline the work of processing entities that include not only the state, but counties and tribal nations as well. The new eligibility system would improve equity of healthcare access, and it would include self-service tools, online plan selection, and also the opportunity through those self-selection processes for not only enrollees themselves, but also navigators and assisters who assist people in applying to be able to do it in a self-service method. We believe that it's essential that MNsure and DHS undertake this effort simultaneously so that enrollment for the populations across the healthcare continuum is improved. And we also want to help support the no wrong door. So there's a one entry opportunity that continues and that is just further enhanced again around that continuity of care and continuity of enrollment. That is the summary of the 6 proposals from the Healthcare Administration. Thank you so much for the opportunity to go through them and the opportunity to present in front of the council, in front of the committee.
Thank you, Ms. McDonald. Members, we get a little feedback coming on one of them there. Okay. Thank you again. And we'll open it up for questions or comments from members. I do have a question I'll just start off with, and it came under the licensing with Ms. Moti. You talked, there's the additional FTEs and costs, and you talked about the 139% increase in licensing requests. As we see a shortage of providers and workforce, where does the 139% come from that we're needing all these extra people? Is it just a shift? We've got places closing and these are new ones coming online, or could you give us a little more detail on what you're?
Thank you, Mr. Chair, members of the committee, Kalani Moti, Inspector General at DHS. Well, first, in answer to your question, that's over, I believe, I'm gonna pull my notes up here. I believe it's over a 4 or 5 year period. Since 2014 to since 2014 to 2021. So that's been over time. We've continued to see it. We are still continuing to see an increase in license applications in our 245D, so home and community-based services. Even during the pandemic, that's increasing, going up. A lot of them are for the home-based services. So people either looking to branch out is what we're kind of thinking, or adapting to the new realities of our situation and workforce. So we haven't actually seen a decrease in that. Also in our foster care licenses, where we've also seen an increase in application for like relative foster care. So as we make shifts in how we address that and how we work in foster care, that's where we've continued to see an increase in our license application. So that 139% has been over 6 years, and but we're still seeing a shift in the number of home and community-based service license applications that are coming in on that. And also that increase is people are adding new service lines. So as we license more different types under that license, that could be a new application that's coming in when they're adding new service lines, providing additional services.
Thank you. Just a little bit of a follow-up. If this is over 4, 5, or 6 years, have those not been financed and part of past budgets? Being this is all coming forward as one lump sum and showing us quite a number of new staff required. And how much of the work is carried out through our counties, or is this actually all coming through the department?
Chair, Kate, and members of the committee, we have brought this request before in the past. I believe the last time was more in the form of being able to address it is through a licensing fee increase, because right now our fees don't cover the amount of work that it would be for licensure, the licensors on that. So we have brought it forth in the past. As we continue to work on and address it, we do apply all of our continuous improvement principles and things that we can do in order for us to be more efficient on it. And the other thing is I believe when the inception of the HCBS licenses in 2014, that the intent had been to come back and provide for additional FTEs at the time as that was being stood up, and I don't believe that necessarily happened. So as we increase the number of service types or the service lines under 245D, there hasn't also been a subsequent increase in staffing for us to be able to maintain that. As for these licensures are issued out of DHS, so these aren't community-based or they aren't county-based licensures.
Thank you. Senator Cran, do you have a question on this?
Thank you, Cherokee. Yeah,
this.
yeah, I think you were trying to get to the question. We've had significant increases in the DHS budget last year. How many people work in the current unit? How many FTEs are in the unit of licensing where you're asking for the additional 43 FTEs?
Ms. Moti?
Cherokee, Senator, I don't have that number specifically right now, and I'll see if we can get that number. If not, we'll be able to provide it for you after the hearing.
Mr. Chair,
Senator
I
Cran?
appreciate the comment, but I mean, each one of these proposals had to been funded or founded based on what your base is. If you don't understand what the base is or you don't have that readily available, I'm concerned that, the 43 FTE ask, the foundation of it. This should be, we're here, you're presenting this information to us for us to consider, and we need that information for every single one of these programs. Thank you.
Thank you. And that'll be a follow-up later, I think, by the department. So next up, Senator Benson.
And thank you, Mr. Chair. I too have, we've been funding things like crazy. And so absolutely, before any of these proposals move forward, I would suggest we have them compared to the base budget. Generally, we do try to recoup costs via licensing. I'm looking at, for example, continuous improvement and compliance expansion. If we're adding 19 FTEs to reduce waste, we should actually be saving money. I mean, in the past, when the Office of Inspector General brought forward more compliance, it actually resulted in savings. So I'd like this to be reevaluated as part of the it's part of a more robust presentation in the governor's supplemental. Going back to direct care and treatment, electronic health records, several years ago, there was a number of full-time equivalents in direct care and treatment that were not filled. And those funds that were supposed to be for personnel were actually transferred to a systems fund. And so we've been spending money on electronic health records. That number was 14 million. And now you're coming back and you're asking for even more money and even more FTEs. So for direct care and treatment, I would like to see the full spend on the electronic health records for the entire timeline that this was supposed to be implemented. Because if we spent $14 million out of a systems fund a few years ago, and now you're coming back asking for another 8.9 and another 7.6, and we're still not completed and caught up, and there's 25 FTEs, we just don't have good visibility on A, when this will be completed, and B, why it hasn't been completed to this point. I'd also like to know if the 25 FTEs will be ongoing or if they're time limited. With the amount of money and attention this has gotten, and just for perspective for folks listening, this was, I think, 2017 that the 14 million was transferred over to a systems fund. And the number you're seeing here is just general fund recommendations. So there's also a systems fund that they're drawing out of. So we need the full picture of everything that's been spent across time on these electronic health records with the vendors who are doing the work identified. And Senator Curran, I know that you are going to have a hearing on some of these IT systems. I'd ask that this one get a little more scrutiny. The service delivery transformation, thank you, Senator Curran, for being willing to look at this. 68 FTEs when there's already hundreds of people working in IT in the department, and we're drawing down federal money. So for the public's information, this slide is not transparent about what the cost of the system will be, and the legislature has had very little input in this. And again, with service delivery transformation, I've asked a number of times, if you need us to refine legislation so that we have more simplified work rules and can save money, those need to be brought forward. And I'm not seeing that here as part of this proposal. So if we're going to spend money on upgrading systems, let's make sure we're taking the opportunity to upgrade all of the services provided. And then I'm going to go forward to the opiate settlement and Orac updates. I think this issue was brought forward in previous years. If I believe Ms. Moti, I think, commented on this. I think this was in last year's budget request.
I think is it Ms. Motemba Mutasa
Yes.
that could answer that for you?
Yes, Mr. Chair and members, yes, it was brought up last year.
Okay, so this is just taking another run at something. And then as we look at coverage for undocumented children, I've asked a number of times for a count on the number of undocumented children that have been brought from the border to the state of Minnesota. I'd like an update on that. And I know as chair, I don't have a right to ask for all this information, but I think for the benefit of the committee, the number of undocumented children who've been brought here since January of 2021 is important information. We know that they're not actually in our child protection system. And so on a follow-up, if we're going to have coverage for undocumented children, we would need the federal government to identify them. And I think it's their responsibility to pay for this. And so why is Minnesota taking on a responsibility that the federal government refuses to participate in?
Thank you. Ms. McDonald, do you want to weigh in on that?
Mr. Chairman, Senator Benson, I don't have that number, I guess, right with me, but I certainly can follow up and hear your concern around that.
And again, why is the state of Minnesota taking, I'm sorry, Mr. Chair, my apologies. Why is the state of Minnesota taking on this responsibility when it is a federal issue?
Ms. McDonald?
Mr. Chair, Senator Benson, if I can include that in my comeback to just make sure I've analyzed that thoroughly to come back with a sound response, I would be happy to do that.
Thank you. Senator Benson?
Thank you, and Mr. Chair, and that's all I've got for now, but I appreciate the opportunity to ask some questions.
Thank you. Senator Abler?
Thank you, Mr. Chair. So the presentation is done, so now we're just asking questions on everything.
Correct. Questions, comments?
Yeah, sweet. Well, you won't be surprised I have a lot. I'm just going to settle for 3. Is there I was looking in our documents here. I didn't see like a comprehensive budget analysis about how this interacts with the budget forecast. And it's easy to talk about short-term money that's available, but there's 24-25, which is $1.7 billion or something, and I think 2.5 counting, or 2.2 counting the Department of Health, as I understand. But I'm curious, has there been a run into 26, 27? Because some of these are going to continue to grow. And I know the governor is sincere in his desire to help these different groups, but I'm really concerned about the long-term fiscal effects. For one thing, I'm not convinced that the surplus is going to hold up. I mentioned before, we've injected $65 billion into our economy, which is woven its way through and resulted in some increased taxes. I don't believe those truly are going to be sustainable, particularly with, businesses and inflation and all that. So I don't know if is that available? Who's ever going to talk about that? And if it's offline or later, that's good. But if we're really going to consider these in a real way, which I think the governor is hoping we will, we have to know the impact and how it's going to affect the budget. So I've got 2 more questions after that. Okay, Mr. Chair.
Thank you, Senator Abler. Somebody from the department, commissioner, or somebody else want to weigh in on Senator Abler's question?
Mr. Chair.
Oh, okay. Ms. Bailey?
Hi, Mr. Chair, committee members, Elise Bailey, Budget Director for the Department of Human Services. We have not yet done that analysis, but we can certainly provide the information to the committee.
Thank you. Senator
Mr.
Abler.
Chair. Well, thank you. And I appreciate that. And Ms. Bailey, I know your level of responsibility. You're not a budget director. You're not Mr. Showalter or anybody like that. But I just want to tell Mr. Showalter, who maybe is, hey, Jim, that if you're hoping we're going to take this seriously, we will have to know the impact. This is a soup to nuts budget. Everything amazing is in it, except for a lot of things that are left out that I consider to be high priorities. And so I think it's only fair that when it comes to us as a formal presentation, that there should be an accounting for that. Anyway, so I have just 2 more questions. I'll save my best one for last, I guess. But on the Minnesota Care buy-in, there's a couple different proposals to add in 2 groups of individuals, some uninsured ones, and then the undocumented children, which we're all, of course, sympathetic about. Does somebody know how many people you think will be adding over the course of both now and in time? And then I'm also curious, are the rates adjusted from the current Minnesota Care rates in the proposal? Because I know those rates are considered below cost for many providers. So does somebody know that one?
Ms. McDonald?
Mr. Chair and Senator Abler, let me just ask one of my colleagues to weigh in on that just a bit, either Anna Ashby, if you could help me with that response, that would be helpful.
Sure, Mr. Chair.
Welcome, Ms. Ashby.
Thank you. Anna Ashby, I'm the budget manager for the Healthcare Administration at DHS. At this time, we do not have numbers for the population that would buy into Minnesota Care. This will likely require actuarial analysis, which is part of the proposal that the governor has put forward this year. In terms of provider rates, those are not currently contemplated in the language of today's proposal. We are well aware of concerns surrounding provider rates in the Minnesota Care program, and also would like to note that in 2021, the legislature appropriated funds during the special session to examine Minnesota healthcare programs rates that will help inform future action on those rates.
Senator Abler.
Thank you, Mr. Chair. And I'm not a lawyer, but I know when you are one, you're not supposed to ask questions you don't know the answer to. But Ms. Ashby, I don't even know if we've met, but I appreciate the answer you can give. But Mr. Chair, this isn't a real proposal. There's the promise that people are going to get coverage, and they don't know how many people we're going to be covering, which is going to cost money because their rates are very low. They're either no fee or just a small fee. And so I don't know, I don't know what to do with that. And so just Ms. Ashby, as you do your study, you might want to talk to the medical group managers who, and clinics like mine and others who do all we can to serve who comes to our door. But I'll give you a short answer to your study. These are all below cost. If you only lived on Medicaid rates for the healthcare, you would go out of business. And so, but what that means in addition, if you add in however many tens of thousands of people, you might want to tell the unions who are working, the nurses, that if this goes forward, they seem to like the idea, and I'm friends with them a lot, but they won't be able to pay the rates we need to get the nurses to go work in these places because they are unsustainable rates. So that's just my little feedback to you about that. And anyway, Mr. Chair, I have one last question, and it's on page 5. It's the caregivers, whatever it's called, thing, workforce revitalization thing, and $115 million. And I read the content here, and I really didn't. Mr. Chair, I feel like I'm sounding crabby today, and I am not crabby. It's been a great morning, and a lot of good things are going. I had lunch, but could somebody tell me a little more of the content? So the proposal is just for words. The proposal we put out yesterday, I think, has more detail in terms of how many people we intend to cover, what we're going to do with it, and how it's going to be distributed. So can somebody offer me an idea of who they think is, I mean, it's open to everybody, it looks like, various kind of workers, and they're all optimistic that they can get all that money. And so, but is there an idea about how many people would be served and what they'd be getting? You know, I think there's a cap in there of 5,000, but if you do 5,000, it only covers 23,000 people. And in our project, Mr. Chair, we found 208,000 people, 206,000 people just in the home and community-based long-term care, assisted living nursing homes cluster. If you add in healthcare workers, you're well above 300,000. So I'm just curious to whoever can tell me about that, how this might work and what you really think how many people are really going to be affected by this? Is that a fair question? I'm really not crabby, Mr. Chair. Thank you.
Thank you, Senator Abler. And this section of the presentation fell under Commissioner Harpstead. Is that for you, or will somebody else be able to answer that? Commissioner, I see you're open.
Yep, Chair Utke and Senator Abler, I'd like to have Elise Bailey answer the question. She worked up the detail of the proposal.
Ms. Bailey.
Thank you, Chair Utke and Senator Abler. You're correct that the maximum award amount for each individual worker would be 5,000, but that is the maximum. And the vision behind it is really to have a flexible pot of money that really works with each provider's excuse me, each provider's demand and how they would utilize the funds. And so we are not assuming that each worker would get an automatic $5,000 incentive, but rather it would depend on the needs of each provider, the workers that they would need to see they would utilize the fund for, and the types of incentives that they would provide, whether it's childcare, transportation, or schooling costs.
Senator Abler, anything?
Well, I do, and just I like the idea of it, and I'm just going to remind you that I'm hoping we can. I mean, I don't want to criticize your efforts. You put forward $115 million in cash. We put forward $322 million in cash. We're trying to cover 206,000 people with $1,000 retention bonus if they stay working for 6 months, if they're working now. And we want to try to hire 20,000 new people and giving them $3,000 per person, including a $1,500 hiring bonus and a $1,500 training. And so I know what those details are. And so I don't want to badger you. I like all of you too well. But I think it would be really useful if you could offline, Mr. Chair. I think I don't be accused of badgering. I'm a gopher guy anyway, so no badgers going on here. But I think we really need some substance to this, because it's the kind of thing I would take to staff and say, write me this idea, and then Mr. Monahan or whoever else would try to put that into legislative language. And so maybe the language will be more clear, but I really think we need to know what's the philosophy. Who do you think you're going to be targeting? Because I would just remind, let's see, I don't know if this includes healthcare workers. Ms. Bailey, does this include health workers or just the long-term care side?
Ms. Bailey?
Senator Abler, this proposal includes direct care workers who make a wage of $30 or less, who work in the fields of older adults, people with disabilities and behavioral health and housing.
Okay.
Senator Abler.
Well, thank you, Mr. Chair. So you have added housing into our number, but I just want to point out for the math of people at home, because I always like math. If you have in the range of 200,000 folks, which seems like what you have, that's about $700 a person, something like that. Not even, yeah, something like that. And $700 a person is 30 cents an hour. So, and I'm taking this time because I'm truly curious, but also fixing this is really expensive. I was shocked when I wanted to give $1,000 to people. It cost $200 million just to send out $1,000 to try to keep them working. So Commissioner and Ms. Bailey, our bill is going to be moving, and hopefully you'll work with us on that. And hopefully we all can work together to take your ideas and our ideas and make something that will truly be beneficial. I'm done, Mr. Chair. Thank you.
Thank you, Senator Abler. Senator Nelson.
Oh, thank you. Thank you, Mr. Chair. And I'll address my comments. I'm not sure to whom, but I trust that you will know who should answer these. I do have several questions about the governor's budget proposal, and I'll ask those in a minute. But I'm going to start with first a comment. And it's a comment that this is the second. Normally, I wouldn't comment on these type of things. I mean, yes, I am a former teacher and spelling is important, but this is the second time that I've seen this error in the governor's budgets or in documents that have come before us. And for the 164,000 people who live in Olmsted County, I want to make sure the governor's office knows that Olmsted County does not have an A in it. So Olmsted has been misspelled again on page 6. So let's make sure that everyone knows that the county Olmsted does not have an A in it. I know the Olmsted court case does, and I can understand the confusion there. So just want to, but now to the questions that I really needed some answers to. The first one has to do with the governor's address growing healthcare costs, something important to all of us, but his initiative to extend prescription drug price transparency. And my question there is, it's about $1.8 million to include pharmacy benefit managers and wholesalers in the price transparency. And I just want to mention that there is really a no-cost way to do that. I'm hoping that the governor might support this, and that is that pharmacy benefit managers, if the money goes to the consumer, if the money goes to the plan holder, then we would not have all of these price transparency issues. So I think there's a simple way to do things, which is make sure that the rebate goes to the person who's purchasing the drug. So no, I guess no comment needed there. But I did have a couple questions on the opioid pieces. One had to do with the substance abuse prevention. Well, actually, I think both of them did. And I just wanted to question why are we maybe This is using, what I'm looking at here, it looks like it's using about $5 million a year of general fund money for this important initiative, but I just want to know, why can't we use the opioid settlement money? So I don't know if somebody can address that in a short amount of time. Why can we not use the opioid settlement money instead of, $15 million from the general fund?
Is that Miss Mutamba? Mutamba, oh, I'm really butchering it. Mutasa. I'm sorry.
Mr. Chair, thank you. So the opioid settlement funds are going to be distributed between the local governments and Orac, which is the Opioid Council. And the local governments get to decide how they use those dollars. And by the same token, Orac gets to decide how they use those dollars as well. And that's really not a decision that the governor gets to make. And so that is the reason why it's not part of this proposal.
Mr.
Senator
Chair,
Nelson.
just to follow up, thank you. Well, is there anything preventing Orac or the counties from using their opioid drug settlement money for prevention?
Ms. Mutamba Mutasa?
Mr. Chair, when you look at the use of funds from the settlement dollars, prevention is part of that. And again, the different entities that receive the dollars get to decide how much goes to prevention, but prevention definitely is on the list of potential uses for this money.
Thank you. And then
Senator Nelson.
just a follow-up comment. Is the governor afraid that they won't support prevention with these dollars? I mean, that's kind of what I'm maybe reading between the lines here, but maybe it's just a belt and suspenders move here. So that would be something that I'd be interested in, is actually using those opioid relief dollars for actually a prevention. I did want to compliment the governor and the proposal on the lead remediation in our schools and childcare settings. That is an important piece that we absolutely need to do. It's the right thing to do. And there's no safe level of lead. And certainly exposure leads to long-term consequences for our kids. So just a brief comment there. Just another comment. I don't know that you need to reply to this, but I'm disappointed to see about $44 million in here for the legalization of adult use cannabis. I'm very cautious about that, very, very concerned about that. And then I did have another question too, if I might, Mr. Chair. Might I ask another question?
Yeah.
Briefly.
Yes, Senator Nelson. One thing, this was pretty much MDH.
Oh, I'm
And
so
I think you're
sorry.
getting into,
Yes,
DHS, and you're looking probably more on the health side on some of that.
yes, Mr. Chair, I so apologize. I was in another meeting and came in late. I will save the rest of my questions, like about Merck funding and such, for the appropriate time. So we'll not need, although Olmsted still is important to be spelled
That's
correctly.
still-
I just want to make that clear. All right.
Thank you.
Thank
Okay,
you.
Senator Draheim.
Thank you, Chair Etke. And I heard if you spelled the county wrong, they don't get any funding. So
We're going to correct that, Senator.
that's what I heard. My question for the commissioner probably has to do with FTEs. For the public out there, anytime we have a proposal, there's usually a fiscal note, and when the fiscal note comes back, there's always an ask for FTEs or full-time equivalent employees. So just looking back last year, which was a budget year, how many FTEs were requested and how many were granted?
Commissioner?
That's a good question. We'd have to look up and get back to you about I can tell you that while we have often added FTEs to each bill when we come forward with fiscal notes, we have particularly noticed over the last year that we have not been able over the years to add enough compliance, finance, and HR people to our bills to keep up with the demands in those functions of the Department of Human Services. You know that we passed record legislation last year, not we, you, last year in terms of a very big budget. And it's taken everything for us to keep up with implementing all the things that were in that budget. And this year, we can particularly see that we have not been able to put in enough FTEs and fiscal notes and bills to keep up with the demands on our finance department, our compliance department, our HR department, and our licensing division.
Senator Draheim.
Thank you. So I guess, yeah, Commissioner, good to see you again. And I could get some follow-up on what was, let's just go back 5 years and go look at what's been requested and what's been granted. And then with this supplemental budget too, I don't remember the number. I thought I heard a number, but what FTE count are we looking at? And et cetera from there, if we could. Thank you.
Can do it if I could. Excuse me. I'm sorry, Chair Utke and Senator Draheim. I just also want to make note that we looked recently at the fact that our administrative budget is 3% of our total budget. I've never been in an organization who had an administrative budget of 3% of their total budget. And I appreciate this sounds like a lot of people, but it's also a large department with a lot of budget to process and a lot of work to do that comes out of each session. And so I think these are appropriate numbers for keeping up with all the level of things that Minnesota expects from us.
I think the answer created another question. Senator Draheim.
Thank you, Chair Utke. So for the public, we look at general fund discussion here, but you also have other sources of revenue, fees and federal money that comes in. Is that correct?
Commissioner?
Chair Utke and Senator Draheim, yes, of course.
So
Senator Draheim.
you do get a chance to take some administrative costs out of the federal funds. I know that. But what is the general fund portion now? What did that raise to after the last session?
Commissioner Harpsted?
Chair Utke, I'd have to ask Elise Bailey if she happens to know that number off the top of her head.
Ms. Bailey?
Senator Draheim, unfortunately, I don't have the updated information after last session, but we can certainly get that to you.
Thank you. Is one of the staff members available that would know approximately what the general fund budget was for a biennium for? I guess we'll take that offline. Thank you.
Thank you. Senator Nelson.
Oh, thank you, Mr. Chair. I believe this is directed to the right person here. It does have to do, as I mentioned, with that healthcare access fund. And I believe I'm looking at the right documents here that the DHS supplemental budget package summary does include 63.8 million from the healthcare access fund in fiscal year 22-23, that biennium, and in the next biennium, $110.1 million from the healthcare access fund. Is that, that's what I'm seeing on page 3 here.
Which pages are you looking at, Senator Nelson? I was just looking for page 3.
Okay, I'm looking.
Slide 3. Okay.
I'm looking at the Walls-Flanagan 2022 budget priorities
Okay.
and the DHS supplemental budget package summary.
I see exactly what you're looking at.
Yes.
That beginning of the presentation was Commissioner Harpsted. Is that going to be something you can take, or should we pass it to someone else?
Those, yeah, you're looking at the right distribution of our budget proposals. I thought the question was more about last year or our baseline in terms of the general fund.
Oh, I'll ask
Senator
my
Nelson?
question. Yeah, I just want to make sure that I was addressing properly here. I just want to know about the healthcare access fund. Is this are these the balances in the healthcare access fund? If you can just kind of explain a little bit what those numbers are.
Commissioner?
Chair Epke, I'm going to ask Elise Bailey then to address that as well.
Ms. Bailey?
Chair Eki, could Senator Nelson please repeat the question and point me to what page she's referencing? I apologize.
Yes.
Sure. Senator Nelson.
Thank you, Mr. Chair, and thank you for your patience. So I am referencing the document, and maybe I can hold it up for you. It looks like this.
I believe it's slide 3.
In this packet. And what I want to know is, of course, I'm very protective of the healthcare access fund. It is, 2% added onto every healthcare service in our state. And so I just wanted a brief update as I'm looking at the DHS supplemental budget package summary, what the healthcare access fund for fiscal year 22-23, 63.8 million, and fiscal year 24-25, 110.1 million. I just want a very brief description of, is that the balance of the funds? Are those funds you're planning to take out of the healthcare access fund? I just want a very brief description of what's happening with those 63 million or 110 million each of the bienniums.
Ms. Bailey.
Senator Nelson, Chair Eki. Yes, those are the total costs of the entirety of our budget package that has come out of the Healthcare Access Fund. The majority of those costs are in the Minnesota Care buy-in proposal.
Senator Nelson.
Thank you, Mr. Chair. So that is really the genesis of my question then, is that we are making health care more expensive by rating the healthcare access fund, but then to turn around and spend it somewhere else. And then at some point, you probably don't have this information right here, but I do want to make sure that all Minnesotans know that this healthcare access fund, as I said, increases the cost of every healthcare service by 2%. And so I think that's significant. But my question is, what does this do then to the healthcare access fund? Removing this much money from the healthcare access fund, how do you anticipate the fund to continue? Are you seeing negative balances there? Are you going to increase the cost of healthcare by increasing the surcharge or the funding that goes to the healthcare access fund based on every healthcare service? I'm just not clear what you're anticipating for the long-term stability then of the healthcare access fund.
Ms. Bailey.
Senator Nelson, we can get you information about the Healthcare Access Fund fund balance and what would occur with the projected spending that will come out of the Healthcare Access Fund as a result of the governor's budget. There are additional proposals that are impacting the Healthcare Access Fund outside of the space of DHS. And so we'll provide that on an enterprise level for the committee.
Thank you. That is my
Senator Nelson.
concern. Thank you, Mr. Chair. That is my concern, the health of the Healthcare Access Fund. Thank you.
Thank you. Members, any additional questions? I think we've run through our list. So, and we do have one more segment to our hearing here today. So with that, I think we will go on to the next section. So thank you, Commissioner Harpstead and staff for your presentation. And let's move on to the MNsure presentation with Mr. Nate Clark. Are you with us, Mr. Clark? And
yes, I am.
you pop up here, please just identify yourself for the record and continue with your testimony.
Thank you very much. Good afternoon, Chair Utke, and also members of the committee. My name is Nate Clark, and I am the CEO of MNsure. Today, I will be discussing one item in the governor's supplemental budget, and we've prepared a few slides to go along with my remarks. The governor recommends upgrading and replacing the core technology that supports MNsure, the state's health insurance marketplace. This proposal improves the experience for Minnesotans who use the technology to apply for, shop, enroll, and maintain their enrollments in a qualified health plan, or a QHP as we call it, but doing that work through MNsure. The proposal also improves the systems and tools caseworkers use to manage enrollee information. Before I get into the detail of the proposal, I'll start with some quick background for the committee. MNsure was established in 2013 to ensure all Minnesotans have the security of healthcare. Our goal has been to promote consumer choice, reduce healthcare disparities, simplify the process of enrolling in a QHP, and facilitate transitions in coverage for those Minnesotans who move between a QHP and a state public healthcare program. MNsure is a one-stop shop for private health insurance and public programs. Minnesotans looking to access a private plan on the individual market or Minnesota Care or medical assistance can visit MNsure.org, fill out an online application that determines their eligibility for those coverage options. The committee requested that we provide a quick overview of MNsure funding and the services we provide. This slide summarizes the resources MNsure has available and our annual expenditures. Speaking first of resources, MNsure received Federal and State American Rescue Plan, or ARPA grants, amounting to about $3 million. We used those grants to modify our technology system so we could make expanded ARPA benefits available to Minnesotans. Eligible Minnesotans received an additional $73 million in federal premium tax credits as a result of these investments. MNsure also received about $3.8 million from the general fund to replace the premium withhold revenue MNsure lost as a result of reinsurance lowering premiums and reducing the premium withhold that MNsure would otherwise have received and used to fund operations. Through an interagency agreement with DHS, MNsure is also reimbursed for costs we incur or services we provide that support the medical assistance and Minnesota Care programs. Some examples of this reimbursement would include the Navigator program, outreach grants, the Assister Resource Center, Navigator payments made through the Consumer Assistance Program, and a proration of contact center operations, communications, marketing, and a few other support services. Speaking now of expenditures, the largest expense category is customer service, and the contact center accounts for about $12 million of that amount. Other customer service expenditures include community outreach grants, the Navigator and Consumer Assistance Programs, the Assister Resource Center, and support for functions like eligibility, enrollment, plan management, and insurance carrier relations. IT costs amount to about $7.9 million and represent just over 21% of our expense budget. The final item I'd note on this page is the balance section at the bottom. Balances carry forward from one fiscal year to the next, and that point out that funds here can be allocated to expenses that aren't reflected in the budget or that occur in the next fiscal year. For example, a portion of the reinsurance replacement funding is carrying over to the last half of calendar 22, which of course will be the first half of fiscal 23. The fiscal 22 budget also shows 100% of the ARPA grant funding that MNsure received, but only a portion of that grant funding has been used, and the remainder, about $1 million, will carry over to fiscal 23 when MNsure incurs those costs. Moving to the next slide, the application and eligibility technology platform used by MNsure was launched in 2013 and is shared by our partners at the Department of Human Services and counties. The platform is referred to as the Minnesota Eligibility Technology System, or METS, and since the launch in 2013, MNsure has worked with our agency partners to upgrade the platform and improve service delivery for Minnesotans. In addition to shared maintenance and upkeep of the METS platform, MNsure has also made strategic investments that improve the consumer experience for Minnesotans who apply for qualified health plans. This work has paid dividends. For several years now, we've seen record-breaking signups with hundreds of thousands of Minnesotans coming to MNsure to enroll in comprehensive health coverage and to access the federal tax credits that reduce the cost of their monthly premiums. Our recent efforts include a 2019 project to replace the legacy plan shopping and enrollment technology system. In addition to simplifying and streamlining the plan comparison, shopping, and enrollment process, the new technology also enabled MNsure to better manage and report consumer enrollment information and to interface with insurance carriers and federal systems. As a result of the investment, we've seen substantial improvements to MNsure operations and significant improvements for consumers. The value of the 2019 technology investment became even more evident when MNsure was able to leverage that technology to rapidly implement program changes that were mandated by the American Rescue Plan Act of 2021. Our ability to implement these changes ensured that Minnesotans could access the enhanced tax credits available as quickly as possible. However, there are still structural limitations at the underlying application and customer management technology, and these limitations continue to hamper our efforts to further improve service delivery and to reach more uninsured and underinsured Minnesotans. Now, MNsure has responded to these limitations with manual work processes and higher staffing levels, and through frequent costly upgrades to the IT platform. These improvements are incremental, however, and don't address the constraints that prevent us from offering Minnesotans the service experience that they want and need. The governor's recommendation recognizes that upgrading the legacy IT platform is necessary to providing a streamlined, simple, and more efficient application and enrollment experience that's easy to use and that removes barriers that make it difficult for Minnesotans to access and maintain health insurance coverage. As a result of the proposal, MNsure will be able to reach more of the Minnesotans who need us most, those who are uninsured or are underinsured. It'll improve service delivery and create a better consumer experience. It'll become a more agile and efficient operation for MNsure, and it will establish a solid technology foundation that will bring us into the future. So what exactly does the proposal deliver? It preserves the no wrong door approach for applying to health coverage, so Minnesotans will continue to come to MNsure to access health coverage as they do today. It introduces consumer self-service capabilities so enrollees can quickly and easily access their account information and report updates without having to call the MNsure contact center. It improves access for limited English proficient Minnesotans by providing an application and enrollment experience in multiple languages, including notices and other consumer notification. It introduces a new assistant portal that improves service capabilities for navigators and brokers who help Minnesotans apply and enroll in coverage through MNsure. It upgrades the systems caseworkers use to access, maintain, and update consumer accounts. The upgraded IT platform will have lower maintenance and operations costs, will be easier and less expensive to modify and upgrade, and will have the flexibility to support future federal and state healthcare regulatory changes and policy innovation. And finally, it'll generate a more sustainable operation for MNsure, including permanent annual projected savings to MNsure's budget of over $4 million beginning in fiscal 25, and reductions of thousands of hours in staff and consumer time spent on manual processes and calls to the contact center. This next slide provides a quick overview of the fiscal impact of our proposal. Costs for the proposal include minute cost to decommission QHP programs from the legacy system, licensing of a replacement application eligibility, a sister and other technology from an outside vendor, and 1 year of maintenance and operation costs as we transition to a fully operational IT system. The total cost is about $18.8 million over 3 years. One final thing I'd note is that we've been hearing from and engaging with stakeholders for quite some time on many of the issues that this proposal is designed to address. The proposal will greatly improve the experience for the Minnesotans we serve, and we're pleased to be able to continue to work with those stakeholders in the coming months, many of whom we know are looking forward to the system upgrades and features a modern IT platform can provide. Thanks for your time, Chair Utke. We look forward to answering any questions you have today and working with you as the session moves forward.
Thank you, Mr. Clark. I do have a couple questions here and then two others too. How many Minnesotans signed up for or signed up through MNsure for their healthcare coverage this past year?
Yes, there were about 168,000 Minnesotans who came to the exchange to enroll or to sign up for coverage. Of that number, 134,000 signed up for a qualified health plan, so on a private program, and the remainder applied for a public program, either medical assistance or Minnesota Care.
Okay, thank you. There are people that go on, access the site, the platform, and probably get partway through and then just either give up or have other ideas or whatever. Are you able to track the number that actually access the platform, but maybe don't purchase at all, as far as, does it give you any data to the numbers, or, you know, that type of thing to know volume?
Yes, it does. So for example, we know that we hosted 1.3 million sessions on MNsure.org during the most recent open enrollment period. We know that we only signed up 134,000. What that doesn't help us understand, Cherokee, is how many of those folks are actually coming back to the exchange through multiple visits. They need to provide more information. Perhaps they've completed an application, have come back to do plan comparison shopping. So we do have information about accesses of the IT. We could actually provide that for the committee if there's interest for a larger period than last year's open enrollment period, just so the committee would understand that there's not actually a direct one-to-one correlation between the number of folks who come to the exchange and those who actually do eventually sign up for coverage. In as response to the question, or at least the part of your question that might be suggesting complexity and difficulty of the system. One of the reasons that we maintain a network of assisters around the state is because we understand that the whole process of completing an application and also choosing a plan that's right for a consumer's family can be really daunting. And so that's why we maintain these network of assisters around the state. These are partners who are able to work with consumers. They live in the community that can help them understand their options. And of course, the best news of all is that they provide those services free of charge.
Thank you. And I kind of figured there would be a larger number, because just being in an insurance agency where you would see the people come in to talk to a health agent, people do get into it and find out this is way more complicated than what they understand when it comes to coverage for healthcare. So with that, I want to go over to Senator Abler.
Well, thank you. And I feel like I'm kind of out of practice talking about MNsure, so here we are. So just a couple of questions. I'm sorry I missed your name, sir, but maybe you mentioned this and I might have been distracted, but what rate are we charging as a fee these days? I think you can go up to 3.5, can it? Or I just don't remember. You know what the rate is now currently? I'm sure you do. Mr. Clark? The fee.
Thank you, Mr. Chair and Senator Abler. The premium withhold rate is currently 3.5%.
And that's the max.
Senator Abler?
It's the max, as I recall. And I also remember, Mr. Chair, when I was on the conference committee to set this up, thinking that Minnesota should have its own. I had Amendment 399, which requested a budget report. We couldn't decide. I tried to get it to be under the governor or the department, but it's a freestanding thing. And so we got a budget report. So is there more detail than this to the report? Like how you spent your communications? I'm sure there must be annotated pages. And how could I get a look at that, please?
Mr. Clark, did you get a chance to catch what the question was, or what he was referring to? You were referring to the page with the,
just this
which was page 3 or the slide 3, I believe.
Yes, thanks. Thank you, Mr. Chair and members of the committee. On our website, we do have a more detailed version of the budget. I just summarized it for presentation purposes today. We would be happy to meet with the committee or meet with you, Senator, if you'd like, and take you not only through that budget, but also a greater level of detail. Of course, we have the information about how we are allocating our resources, and more than happy to help you understand that.
Well, I guess there's 2 line items.
Senator
Sorry, Mr. Chair. There's 2 line items, and especially the administration and then the customer service would be interesting. And then finally, what happens if we don't find $20 million to give to you to do this technology? What's going to happen if that doesn't happen?
Mr. Clark?
Thank you, Mr. Chair, members of the committee. I think it's just important to understand that, I mean, as an exchange, we've had a very successful open enrollment period. Consumers are coming to the exchange. They are enrolling in coverage. We're providing the best service that we can. What we recognize, though, is that the current limitation, the IT limitations that we have, are really preventing us from doing a good job of serving Minnesotans and providing the kind of service that they deserve. One of the key features, for example, of the modernization proposal would deliver self-service capability. This is the kind of thing that all of us have come to expect simply by, working every time we book a flight or we go to Amazon.com. We want to be able to change our address or indicate a change to a piece of information that MNsure is holding about you. But our current systems won't allow us to do that. In preparation of this proposal, we took a look at fiscal 21 data, And our analysis suggested that self-service capabilities would have reduced the most common call center calls by about 55%, from 285,000 to over 128,000. Keeping in mind, of course, that every one of those calls represents a consumer sitting on the phone talking to an agent and an agent working with a consumer. What you can understand is that we're talking about tens of thousands of hours that could be saved. So I would look at it and say that we are talking about an investment, but it's an investment that's going to be needed and that will have measurable, I think, and very important improvements for all the folks that are dependent on MNsure for the services we provide.
Senator Abler.
Mr. Chair, I just have to apologize. The cobwebs are coming out of my brain on this. So, I mean, that's Mr. I should have got your name. I'm really sorry.
Mr. Clark.
Mr. Clark. Yeah, thank you. I have too much on my screen here. And if he didn't really answer the question, what happens if we don't do it? They're not going to be able to do their own self-work. But I just remember how much money we spent on this thing. It was a record-setting amount of money. And some of these functions are kind of like basic. And actually talking to some folks, it's not that legendary of a program, and maybe they're trying to fix it now. But anyway, I'm concerned about this. And maybe Mr. Clark, and when you get that other information to me, if you just maybe send me the cut and paste of the communications and the customer service, what are those two things? The administration and the customer service detail, that'd be great. And also if you could include a detail on these expenditures, because I presume if you have savings, if you have costs and you said there's savings, that would be reflected in your fiscal note. So there must be a fiscal note that I would like to look at. And maybe the committee would like that, Mr. Chair. So thank you very much. That's all I have.
Thank you, Senator Abler. Mr. Clark has things to do, right? But Senator Nelson.
Oh, thank you, Mr. Chair. Mr. Clark, I am well aware of the METS problems that are cascading down to our counties. And I'm hoping that this fiscal request is to replace that software. And I'll be glad to talk to my committee members here about exactly what it's costing the counties. But I assume your request, can you speak to me a little bit about your request and maybe shed some light on what some of the problems are with METS and how our counties are needing to come in, at least in some that I'm aware of, and actually have had to hire people to manually enter because METS has so many problems.
Mr. Clark.
Thank you, Mr. Chair, and also Senator Nelson. I think you've summarized it very well in just acknowledging that METS is worse than an imperfect platform. It has not actually, it's very complicated. It is expensive to maintain. It is very, very difficult to enhance. And as a result, as I mentioned in speaking about the MNsure side of things, what we have seen is that we have to hire people in order to compensate for the gaps in this legacy IT. And so the purpose of our proposal is really focused on developing and launching a system that is extensible, that is modern, that will let us move forward in a way that is actually a good use of state taxpayer dollars, and so that we will be good stewards. I would also just say, and also perhaps this is a bit of a clarification, the investment that we're talking about would not change the front door, the single front door that all consumers come to when they're applying for services. It's important to understand, though, that there are some households in Minnesota that MNsure actually isn't responsible for having caseworker operations on. And so that would continue to be DHS and counties, and they'd be in a better position to talk about the way the investments that they're proposing would address some of the same concerns that we're raising. I think that's kind of an imperfect response to your question, but there are two sides to it. On the public program side, the QHP side, not the public program side, but it's the QHP side that I'm able to speak to.
Senator Nelson.
Oh, thank you, Mr. Chair. And just a brief comment. I would guess that all of your counties are subsidizing the METS program, and it's inability to work. Some of the problems, just briefly, and I cannot speak if it's to the QHP side or to the other services. And so Mr. Clark brings up a good point. I'm not saying this is all about QHP, but the QHP programs, problem is somebody goes into METS, let's say to your point, Mr. Chair, some of these applications get kind of long, insurance is kind of complicated sometimes, and they don't get to finish, or maybe the phone rings, or maybe the baby cries. And then they come back later and they start a whole new application. And there's not a way to sort those out except manually. And so I would, just one last question for Mr. Clark, please.
Senator Nelson, go ahead.
Thank you, Mr. Chair. Mr. Clark, the amount that you have listed here, I think 7.7, 7.4, and 3.5 million, is that only to remedy the METS problems for the QHP programs? Or is that enough to remedy? I mean, it is a significant problem. I think Olmsted County had to hire 8 full-time workers to fix the METS problems. And so I just want to know, is this request that you have here for METS just to remedy the QHP problems with METS, or is it broader for all of the METS related activities?
Mr. Clark.
Thank you, Mr. Chair, and also Senator Nelson. I can try to clarify it. I think that we're going to be the focus will be more on the QHP side, but there will be benefits that will be realized for example, public program enrollees, only because the simple front door will have a better application process. We, for example, will be having better mechanisms for uploading documents, information for managing households that are shared between private programs and QHP programs. But the investment is primarily for decommissioning QHP program from METS. And so of the 18.8 that we have requested, about 11.4, I think 11.1 of that, 11.2 of that is for development, and that's IBM development that will be focused on doing the decommissioning from METS. And then the remainder is on a number of other enhancements we'll be making as we license and then customize the licensed technology for Minnesota's use.
Thank you. Thank you, Mr. Chair.
Thank you, Senator Nelson. Mr. Clark, I've got a couple here. If we get through, we only got a minute or two, we should wrap up here. But the first question would be, we talked the request for the upgrade to the technology and the expense related to that. If that was implemented, and you did comment on the number of calls that the staff currently answers that could be taken care of by automation, how would that affect your FTEs? What do you envision in the end versus currently as far as the savings there and full-time staff?
Yeah, I think thank you, Mr. Chair. That's a great question. The proposal doesn't actually reflect a change in FTEs currently, and that's simply because any impacts to the budget would be beyond the budget horizon for this current proposal. Our plan is, of course, to continue providing all of the functions we do today. So a staffing, a contact center in order to help consumers with both QHP and public program questions, supporting navigator and broker programs, providing oversight to carriers, essentially providing all those kinds of functions. I do believe that it's possible fewer FTEs will be needed once the proposal is fully implemented. And I also believe that if in fact that were the case, we'd be able to handle any reduction in FTEs through ordinary attrition and by reducing the number of temporary seasonal employees we hire ahead of each enrollment period. Back in prior years, for example, we have depended on an outside vendor to provide contact center services, volume services, overflow services. We were able to discontinue that and replace it with a temporary workforce, but the value of that contract in the past was about $2 million. So I think that there are many opportunities for us not only to see savings, but to have those savings reflected in FTEs whose services are really needed and whose services aren't all about just trying to make up for outdated, inefficient legacy IT.
Sure. And I would, just from my own personal point of view, I would value that as valuable information in presentations like this. If we're going to invest in new technology that's going to make us more efficient and streamlined, part of the thing I'd like to hear is, in the end, we could save 20, 30 FTEs or whatever that number might be. I just pulled that rabbit out of the hat, so to speak, but that helps complete the story. And I think that's something we miss in a lot of presentations. So not necessarily picking on you, but that is information that I believe the committee would like to see and hear. But one last thing, the information that gets entered online when somebody signs up for coverage through MNsure, how is that audited to know that what they actually put on there is true and they aren't just, I'm smart enough to figure out how to get a good rate?
Thanks, Mr. Chair. We do have a number of compliance and verification processes in place. And these range in everything from automatically taking information that was provided by the consumer, comparing that with information on the Federal Data Services Hub. We actually have a link to the hub. And so every time information is provided, if it's something that's important for eligibility determination, we ping that federal hub in order to make certain that there isn't a discrepancy. And if there is a discrepancy, then we generate a notice and we actually work that notice with consumers to determine that the consumer is eligible for the benefits that they are claiming as a result of or through the application process.
Super. Well, thank you very much, Mr. Clark. I think we've reached an end here of questions and we've used up all of our time. So I appreciate you and everybody else for joining us here today. And with that, the committee will stand adjourned until next Monday. Thank you, everybody.